Kasey, I want to introduce you properly because, it's been just a little bit over, well, it's been 2 years now, coming up on 2 years that you and I have known each other. From coming down and filming you in your practice, our team did, and then with some work together with RX Site, and then you speaking at their national meeting. And really, I came to respect you a lot through how you implemented that technology. It's one thing to be a leader. It's another thing to figure out how to, understand the rudiments of engaging the team to deploy an asset as complicated as glaucoma care, interventional glaucoma care, refractive surgery, refractive cataract surgery. And and the things we're talking about today, last time I think we talked about the light adjustable lens. Today we're talking about interventional glaucoma, and I think it's apropos because we're staring down the end of the year, where I've got to check my some of my notes, but at least it's still unknown as to whether or not we're going to have some cuts coming up here on the implant side of our world, on the cataract side of things. And while some people are calling foul, practices like yours are getting busy with other categories that can service patients well. And so that's kind of the theme of today. How do you engage the team and build workflows around things like interventional glaucoma? But really, I think the key is that once you've learned how to implement really anything, the light adjustable lens, interventional glaucoma, refractive surgery, if you pay attention, you've now learned how to implement everything. And so that's what we're going to talk about today. And we've got a few questions to get us going. But Kasey, thanks for coming back. And you've provided a lot of value for us. And hopefully that's a two-way street. I want everybody to know you can interrupt us at any time. We're going to have a conversation about what she's learned in the last few months about interventional glaucoma. She and I have talked about it a lot. And she's actually hosted and spoken publicly about interventional glaucoma and how they're implementing it at their practice. So we hope to learn a lot from you today. Just a reminder, everybody, this session, Practice Habits, is set aside for leaders in the field of running practices, recovering administrators, current administrators, to figure out how do we take all this great technology matched with a patient who can benefit from it, but then run the table on, insurance and staff involvement and training and making sure that, we're recommending the right thing and that we're not recommending something that the doctor is going to find isn't covered. And then there's egg on face and everybody loses their fervor for doing the right thing. How do we make the right thing to do the easiest thing to do? And so we talk about that every week and on a rotating basis. And so thanks for joining us, Kasey. Maybe just give us a little overview. Where are you in your practice right now with interventional glaucoma and as compared to a few months ago? Because it's really started to grow.
It is. And I would say where we're at is obviously we're not at the finish mark. And interventional glaucoma, well, easy enough for me. Our providers, we as soon as we started to understand the consensus for interventional glaucoma, it was my providers are really quick to say, this is impactful, it's meaningful, and it is something that will matter to us. And I'm like, but we don't see that many glaucoma patients. and data proved that otherwise. And it really wasn't like it wasn't the bread and butter of our practice. I'll just be honest with you. Glaucoma patients were patients that we were seeing for sure. Um, but they were not our bread and butter. Being comprehensive refractive, we were focused on premium IOLs. And I think it's very common. You and I've talked about this before, Matt. I think it's really common to just put those blinders on and not focus on the comprehensiveness of what your practice can do, because this one thing is working really well. So you just keep heading down that track. Where we're at today is definitely way beyond where we started. First, we had to, recognize that there was an established base of patients that we already had kind of in a closet, right? of patients that needed treatment and were lost to.
Let's talk about that for a second because for two reasons. One, I want to give you a time to take a drink of water. Thanks for doing this when you're recovering from a cold.
Thank you.
So you're battling through, and I appreciate that. Two, you're well known in the Dallas marketplace for laser vision correction, for implant vision correction. You said you're a comprehensive refractive surgeon. I love that because what that means, to people like me is, corneal procedures, that's implant procedures, that's phakic implant procedures,
Yep.
um, and so all the whole gamut. But and yet you think, well, we don't have any of these patients in our program, so what are we, why are we paying attention to this? So what was the discovery, and how did you find out that you actually do have glaucoma patients walking around?
Yes. So the very first thing that we did was pulled data out of our EMR system and also out of Salesforce. CRM is what we were using. Weren't necessarily using Salesforce to track any of those patients. It was mostly set up to track premiums. And so, but we pulled data out of our EMR PM system. How many times have we seen these glaucoma diagnoses? And then we had to very manually go in and attach when their last appointments were, when their upcoming appointments are, what happened with this patient, did we do anything with them? It was quite the task initially, and it took some time, but once we realized, we were just kind of mind blown.
Hmm.
And honestly, um, when our providers saw that, it was we felt almost like we owed a debt to a established patient base that we hadn't successfully treated.
Yeah.
Even
So
though,
I just want to paint the
even,
picture properly because it's not like you had, quote, glaucoma patients walking around
right.
in your practice. You had cataract patients
Yeah.
who happen to have glaucoma,
Yeah.
right?
And you know, in all honesty, we weren't discounting a glaucoma procedures. We were doing a small amount of stents and treatment for mild to moderate cases, but with the knowing of what comes behind. I know we're going to get into reimbursement and everything, but with the knowing of what comes behind all of that, our focus being very much on vision correction, that's where we were,
Hmm.
you know.
With that patient base now, so you've got refractive cataract surgery patients, traditional cataract surgery patients who are coming in, and and while you're not necessarily the go-to person for their glaucoma care, they might be going to another specialist,
Mhm.
or they might be in the offices of your primary eye care provider, kind of partners in the community, which is where a lot of them reside.
Yes.
But yet they come to your office and you could probably do something about it because you're a millimeter away from where a stent goes, and you're already in the eye. Talk to me about that discovery. How many patients, I mean, some companies will say it's one in every five cataract patients has severe enough um, degradation of vision to have some kind of procedure, right?
Yeah, I would say it was a substantial number.
Yeah.
It was uh, it was a substantial number of patients that that we had, applied a primary angle glaucoma diagnosis to. We didn't even look initially at ocular hypertension or the other diagnosis codes that would fit into IG, but just the POAG patients, it was substantial.
Hmm.
And it was an initial recognition that um, there was something that we could do, and we should do. We owed a debt to this patient base. And you're right, they didn't all necessarily exist. They weren't just walking around waiting for us to treat them. They were certainly in management, may not have been with us. We may
Hmm.
have seen them, two or three times a year because they were being managed by an external provider, a primary eye care provider. But nonetheless, we recognized pretty immediately that there was a good base of patients that we could service, and while also supporting the primary eye care providers. Like, it was a recognition of this is not going away. It's not a curable disease. We can save vision. Now the onus is on us to do something about it.
Right. And before you may have been sending them home with with drops and things like that, but you and Dr. Strange then decide, okay, so we're going to be more interventional. You've got this list now of patients who you know might be good candidates. What comes next?
What comes next? My providers sit down. I get our providers to a table, and we all sit down and talk about because we're very collaborative, right? Top to bottom. We sit down and we talk about what we believe our protocol looks like internally. And what all providers could agree on would be the pathway for clinical decision making for those patients.
Let's stop there for a second because I think that's a really important piece of work that a lot of people maybe don't grab onto as much as I think they could. I go back to the days when I remember we had a bunch of different technology for dry eye treatment, ocular surface disease. And one of the heads of one of the companies were like, wow, you have all of the toys. And I was like, yeah, we're a dry eye center of excellence. And he's like, well, when do you use this one or that one? I was like, I have no idea. I think it's based on the doctor preference. And he says, well, you sounds like you actually have a dry eye circus. And and I took it personally because he was right. And so we went back to the DEWs, the dry eye workshop, who had established protocols of, when do you escalate care to one offering versus another. And then we trained our team accordingly. And that protocol was so helpful to just get everybody like a blueprint of it might not always be this when it escalates, but it's likely going to be, we're going to escalate to this and then to this. It was just a very helpful guide. And so a lot of doctors got together and did that for interventional glaucoma. And then you did that, took that and applied it, what, internally amongst your doctors, basically?
Yes, the direction comes from our provider team. They're the ones making the clinical decisions. So the first thing we had to do was sit down, determine the way in which we were going to, attack treatment protocols and clinical decision making. They did that. And then I was able to work from that footprint, not just forward out to the staff, but I like to take a problem and work it in reverse, right? So, where do we want the patient to end up? Well, we want to intervene. So, if that's what you want to do, backtrack whatever needs to happen within your practice to accomplish that. And so this was just the beginning of the footprint, but it gave me an end result that our providers wanted to get to, right? And so what we did next is I took it to this team, to the staff, first to the leadership team, department heads, and brought them on board, introduced them to interventional glaucoma, the consensus, what it was, why. This is the thing. Everything that we do is about why. Would you agree?
Yeah, has to be.
It's that simple. It is that simple. We're not reinventing wheels here. I want my providers to do what they believe is the best in healthcare delivery. That's what the foundation of our practice is. And I want them to have the best resources to make those clinical decisions when a patient's in the office. And so everything that is within the clinical workflow is to support that,
Yeah,
right?
and ultimately getting back to that why, because you're right, it does drive everything, is that we know that if it's our practice or if it's the practices that are the primary eye care providers out in the community, that even the best intended patients, when prescribed even an effective drop, I was literally talking to one of my best friends yesterday, And he's like, I'm sorry I'm late. I had to pick up drops for my mom. She's in Arizona and she forgot to get them before she leaves. And he's going to FedEx them to her. Well, that means she's losing a couple of days, right? So the therapeutic viability of what happens when you lose a couple of days of a drop that you're supposed to take a couple of times a day, you're no longer managing the progression of that disease. And we know that it's, that about half of people actually fill their scripts, and about half of those fill it again the next time. And it just keeps getting kind of worse and worse. And only does it compound when they actually get on more than one drop, and so on and so forth. So we know when we see these patients in our practice, even if they're on drops, they are likely not under management. So
Right.
intervention means like we got to do something
Hmm.
to get them kind of like stabilized. They can go back on their drops when they're done with that, but we need to at least get a baseline, wall up to hold back this progression. So I just want to kind of redefine what we mean by that intervention.
Yeah, I think that I mean, we're not even talking about the undetected and untreated, right?
Right.
Um,
Right.
we're talking about the diagnosed, right? There's so many more that are just undetected and untreated, that they wait until there's something wrong. If
Yeah.
you don't feel it, you don't see it, it's not like, you know, it's staring you right in the nose. It's not until you have some visual complications that you maybe see
Symptomatic.
there,
Right.
you know.
Okay, so you've got this list, you've got alignment from the doctors, you've got your protocol set, you've got now a team who's looking for these patients and they're coming in. And it's good because we now have technologies that you don't have to fail a therapy first. We can go right to an intervention, then use drops afterwards for a bridge. How do you set it up in your clinic? Or is there like an afternoon where you're just draining the bathtub and having these patients come in just for procedures? Or are you working them in to your regular program? Are you doing outreach to your existing patient base? Where does it go?
So it's interesting, there are, I think, a lot of offices that specifically set up an IG consult. That's very common. And I'm a proponent for that if that's what works for your team. For my team, they like to be very, this is what we're doing, and this is how we treat that. So anytime we're engaging any patient that has glaucoma, so our appointment types are not vague. They're very specific. There are no vague, just follow up or dilated, DFE or there's nothing like that. They're all very specific. Cat new or diabetic new based on disease. And we have patients that are scheduled for glaucoma new. If it's glaucoma new, it's immediately tagged IG protocol, because that's the way in which our providers chose to treat and intervene with glaucoma, with the disease.
So I'm going to stop you there because I want to understand exactly what you mean. So a patient calls in or a doctor calls in with the patient at hand saying, "Hey, I'm sending them to Dr. Strange and your expert team of ODs there. It's an IG new." Okay, so the flag goes up and it's a cue to the team that this is like that a procedure is likely going to happen. We're looking for a procedure. They're coming here for a surgical consult. Will they have it that day, the procedure?
Yes,
Okay.
they won't have the procedure that day, but the clinical decision making will be done that day. And what our team does is, the way we set the workflow up, when the staff was bought into the concept of what the providers wanted to do, the protocol, we're all on the same page now, right? And so what happens is, okay, how can I make my providers, what do I give them free reign to make clinical decision making quickly? And that would mean, well, let's give them some payer specifics. So if it's a new glaucoma patient, our insurance team is verifying all potential procedures that would be included in our protocol for that patient. And they're making a note where the providers can see it so that it's top of mind when our providers go into a room and see a patient, so they know which area they can go to for that patient and make their best clinical decision. for them.
Yeah, and also that they're not making a recommendation for something that they're going to turn around and not be able to perform for the
Right.
patient, right?
You don't want to spend, 10 years talking about a stent or an implantable device, to replace drops, and then you can't get it. There's no coverage for it.
Right.
So
Okay.
we do all of that in advance of their appointment so that we know all the things that we can know about a patient before they even encounter our office.
So I like that. One of the things I just want to ask you, I want to just forecast now the future. Do you foresee a time when your phone team and your counseling team, like pre-authorization team, is so well trained that when they receive that IG new consult, that referral, they're pre-educating that patient. Hey, you're going to come in at 11 a.m. We're going to do some education, but Dr. Strange doesn't like things to progress, so you'll likely have a procedure that day
Hmm.
where we just have an afternoon full of, in LASIK days, we call that a see and do, right?
Yeah. Yeah.
But it's like an IG see and do program. Do you think that will get there?
Yes, it will.
Hmm. I do
Yeah,
too.
I,
Mhm.
I really do. I mean, look, it's no different than, any other laser procedure, and there's no reason to not do it,
Mhm.
right? Um, at least in our practice, the ASC is right next door. So, you know,
Yeah. Well, and so this is going to be a very perverse example, but my wife's a family doctor. And
mhm,
in her training, she was taught that if you have a patient who says, or in their record, it says that they've tried meth, their protocol is they treat them like they're on meth because it's so hard to kick that addiction.
yeah.
And so that's kind of like a medical training. So I imagine, this being something like, you hear somebody's having glaucoma, it's a foregone conclusion they're having a procedure.
Hmm.
And the opposite is also true. If we hear somebody's on drops, it's a foregone conclusion that they're probably not hitting it to a therapeutic level,
Right.
because of human nature. Those two things feel like they're a safer bet. And the thing that I think why we keep talking about it is because still, um, our current standard of care is drops first. And it
Hmm.
just I think we got to keep shaking the tree. Now, I want to talk about it's obviously good for the patient because we're going to arrest the progression
Hmm.
of the disease and then get them on drops
Right.
until they maybe need another procedure down the road, or maybe they won't. Maybe that's all they needed. But let's talk about the economics because the other thing that used to happen is, and it started with MIGs. I remember when we were first starting with those, it took forever to get that through reimbursement. We couldn't do them. We had to do them with cataracts. Some things came out that where you didn't have to do it with an implant, but each procedure had different protocols. And then you weren't reimbursed as much because you had to do it with another procedure. Talk to me about the economics of interventional glaucoma treatments right now.
So with us, I think as far as reimbursement, I think there's some things that are really, really important, right? And to be honest with you, I track this myself. It's not difficult to track it, but I want my team to know the codes. I want them to know the covered diagnoses. We're sharing internal education all the time about policy changes, clinical policy bulletins, what payers are coming online, what payers are not, who's giving us a hard time. We're just, keeping an open line of communication as things come online. It's a little bit of the norm when it comes to
Hmm.
stents, MIGs, that kind of stuff. We know that, right? It's part and parcel to the environment, the landscape of this treatment. Um, but a couple of things: making sure you verify coverage up front, right? Implementing a tracking system, how you can track those claims and ensure if you're getting denials that you're on top of it and you're keeping that claim in cycle and you're, wrestle with the payer. I'm not afraid to do that. I actually have enjoyed wrestling with payers on some of this IG. Um,
I'll bet you're good at it.
it well, RCM is my background, so
Hmm.
I spent a long time doing that before I took on, an administrator role. and I actually enjoy doing it. It is definitely. I'll tell you what has made more of a difficult shift in that landscape is that payers. Gosh, I wish we had payer reps. We just don't have them anymore. I can't call up a local rep and complain about 15 claims that didn't get processed accurately, even though everything meets their medical policy. It's all outsourced, and there's no connection there. So that has definitely shifted the dynamic. Um, but
Let me ask you some clarifying questions because I know that it does create some work to get these things through the system and to get the pre-authorizations we're talking about.
yeah,
But when we're comparing it to, we opened with talking about the decline in reimbursement, right?
yeah,
So uh, can interventional glaucoma be a new offering that has a potential of being a win for the clinic financially?
100%, 100%.
Hmm.
Our providers decided that SLT would be our first approach, right?
Hmm.
SLT lasers. And, we have the laser machine, we've had it for some time, but I can't say that we were actually using it to even our benefit based on the service contract
Hmm.
for it, right? Um, and as soon as we decided to, follow the protocol with step one to SLT, we saw an increase there.
Yeah.
We were seeing an increase there. And mind you, I mean, that's not the same cost as, for example, refractive surgery, but you have one section, LASIK in particular, is, on the decline. It's been on the decline for a few years now, but it's not the same, as
Well,
far.
well, I mean, just give me a rough number between make it within $100 either way of what a payer mix might be on an SLT because it's in your clinic, right? Or is it in your ASC?
We have it in the ASC.
Okay, so can you offer a sense of what the facility and professional fee would be on that?
So facilities around 300, 350.
Hmm.
Um, and I take that back. Did I say facility? Surgeon is around 300, 280, 300. And
Hmm.
the facility is about 250, 280, I think is what it is.
Hmm.
So it's not great, but look, you're doing way more of it than, you ever thought you would do because that's your first step in your protocol. Correct.
Right, and it should be, and it's the reason that that protocol now becomes so important is because now your whole team knows walking in. If they haven't had an intervention, chances are there's a procedure that we're going to do as a first line treatment. Dr. Strange is going to want us to get this patient kind of pre-educated about it, and it's going to yield between $450 and $550, which, by the way, the procedure doesn't take that long.
No.
It's not like LASIK prep. I mean, you can do 5 or 6 of these in an hour.
Yeah.
And
I mean, on a typical laser day, because we schedule our lasers in blocks. In any given laser day, he'll do 40 to 50 total,
Mhm.
lasers, YAGs, and SLTs in a 2 hour window tops, 2.5 hour window. It's
Yeah.
quick.
So I mean, that's why that protocol is so important, is because you basically just decide, hey, team, patients aren't getting out of here without an intervention.
That's right.
It's the best thing for the patient. It's also really good business, but it's
Yes.
the best thing for the patient. And
Right.
so, and so that's your first line. By the way, the reason it's first line is because it's not super complicated.
Right.
It's not super expensive.
It's widely
The
covered.
costs go up from there, and so does the reimbursement, by the way.
Mhm.
But the way I say it is that a mature practice probably has, um, as an average, enough glaucoma patients sitting around to be reimbursed at least as good as cataract surgery does
Mhm.
on
Oh,
that
yeah.
patient. So, and that's not a far cry. And so I guess. back to our opening line. The reason this is so important is while we're belly aching about, a 6% decline on the professional side of cataract surgery, or is it 11? I don't remember. But you've got other places where patients still sitting right in front of you, and we can do something for them that's really of value to prevent their ongoing progression towards blindness.
It's
I want
funny.
to I want to transition us really quickly, unless you've got something more to say on economics.
No, I was just going to say, it's funny. You and I talk about, I think economics, you have to include ROE. It's always ROI and ROE. It's both things.
And what's the E?
Experience.
Right. Yep. Yeah. So imagine the bummer of them coming in for a great refractive cataract procedure, going back to their primary eye care provider, having a few months of bliss, and then that provider's like, boy, I should really send you to a glaucoma specialist. And they get sent somewhere else. They're like, just, somebody just did surgery on me.
Hmm.
Why did they not do it while they were there?
Yeah.
You're exactly right. ROE is uh, at least even with ROI in real time, but long term, it's an annuity. We know that. I wanted just to spend some time talking about the database work because you and I talk a lot about ways to do this. You work very closely with your EHR and PM company, practice management software. But yet they can't exactly run these reports for you. So you rely on, you've got Salesforce for like lead management. That's kind of on the sales side of things. But then you work with Brevium, who've been on these sessions before to help run the list. Talk to me about how that works, and why is it so important?
It's incredibly important because that very manual process that I talked about that we did to determine our data, um, Brevium replaces. And they've done a wonderful job of, integrating with your PM software, and they know exactly how to map out the specific details of interventional glaucoma reports. And having access to that took a load of time off of me, and allows the rest of the team to be able to participate in determining who those patients are, where they are, what we've done. And also, it gives us the ability to maintain data that we can then bring back to our team to hold ourselves accountable to the protocols that we created, which I
Hmm.
think is very important. Like, you don't sit down as a team and decide we're going to do something new and then not, maintain a close thumbprint of the data and how you're firing on those protocols.
And
But our
and
team.
they with their offering, because they're known for reactivation,
Mhm.
right? And wildly skilled at that. But so is this just reactivation? They're finding patients who are glaucoma patients and calling them back and getting them on your schedule, or what's the difference?
Well, they are doing that, and we're using them for reactivations, not just for the glaucoma patients, but really for all of the patients that have been lost. And so we are using them for that. But the IG reports specifically um, are, I call them one-click wonders. So you're clicking down, one report, and then my team then goes in and tags the charts in the EMR. That's how we're using them as baselines to know who we are going to tag for IG protocol, who we're going to verify, and the team is working a week ahead using those reports and placing the flags on the accounts, tracking the patients, and then I use them to go back and hold the team accountable to, uh, you know, the protocol, and that we've accomplished the steps that we agreed to.
So I'm going to just lead you a little bit with this, and they're not on the call to defend themselves. But you know what? I feel like our industry really needs them. They're a key right now for us helping a lot of patients. And while they were born out of a model where they take patients who had fallen off and they kind of get them back to the practice, they also get them from the practice there's like a qualifier with a payer. They
Mhm.
close that gap. And then that payer piece closes the gap with the procedure.
Mhm.
And so basically, it serves up this entire thing. So the doctor and the patient are back knee to knee, having a really important conversation about here's what I recommend for you, Kasey. And if
That's
you were my sister, this is what I would do.
mhm.
And they can do it with no risk, with no embarrassment, because they know that the procedure and the payer and the patient all line up. Is that about the size of it?
Yes. And the thing is it's there's not an EMR system. The beautiful part of Brevium is that they understand how to map to gain that very insightful data, and not everyone does.
Hmm.
Salesforce doesn't. I'd have to teach someone at Salesforce to map this, that. You know what I mean? They already come with the ability to know I want your diagnosis codes, I want your procedure codes, I want to be able to marry all of these things together. And they've done the intellectual work to put behind that reporting. It makes it
Yeah.
extremely meaningful.
Well, I'm impressed by them, by how they've done the reactivation part for 20 years. But I think that that's kind of like that's why they have credibility in this new category, is because they've done that so well. And I do wish that we had practice management systems and EHRs that could do this for us, because we're paying handsomely for those systems. But they're too busy trying to just, develop widgets and, add-ons to their existing patient base for basic functionality, not even, this esteemed or more intelligent functionality to be forward looking.
Right.
Listen, we've talked about a lot, and but I want to just make sure everybody has a chance to ask questions. I know we've got folks who run practices here. We've got some folks from industry. Any questions for Kasey? And I know I interrupted you, Kasey. What were you going to say?
Oh no, I was agreeing with you.
Okay, awesome. Then I shouldn't have interrupted you. I should have just let you. Questions for Kasey? Chris Bonsall, I know that you're doing some pre-education for some practices unnamed, but to kind of pre-educate their patients with your system that an intervention might be a good option for them. Give us 1 minute on that, because it's kind of a test right now.
Yeah, it's I think what we found is there's a lot of practices. I think to Casey's point earlier, there's a lot of practices that do it one way. They have a dedicated interventional glaucoma eval. Some practices are still kind of implementing this protocol. And what we found is, 75 to 80% of the patients that we speak to and educate are highly receptive to some sort of interventional option. And right now, all of those patients we're speaking to are kind of identified in the same way that you mentioned, Casey, right? We're working with Revium within the practices we support to identify patients that strictly fall within certain criteria, right? They have the primary open angle glaucoma, hypertensive. They don't have other comorbidities that might preclude them. They do have certain insurances. We're about to start with some more practices where we're actually combining that education discussion for patients for the ROE discussion you mentioned, right? Patients that are coming in for cataract surgery, which is kind of our bread and butter and where we were born, but that also are candidates for some sort of interventional approach, right? You're already going in to a trusted surgeon to have a procedure done. Why not also consider this opportunity to treat your glaucoma as well? So we're finding really great results early on, and we expect that to continue as more and more practices kind of take on the interventional mindset.
That's really helpful, because I think the next thing is we might have a protocol. We might be able to sit down with our team. Our doctors might be aligned. And great, thanks for serving up all these patients to me. But our team's already slammed. How are we gonna reach those people, who we really want to help? Bill, you've also got a dog in the hunt when it comes to helping practices do that communication. And I know you've got a question for Kasey too. What do you have?
I do, yeah. Well, first off, we were on the phone with the team at Brevium this morning, just kind of
Mm.
talking about this type of thing and how can we generate more volume with different types of patients using Brevium's ability to sift through the patients. So, Casey, first question that I have is, how many patients did you find that fit the criteria when you went through Brevium in your database?
Over 500.
Over 500, okay. And so how did you initially reach out to them? What was your kind of workflow in initially reaching out to them just in
So initially, we started with the patients that were obviously already established, and
Mhm,
then
mhm,
set protocols out for payer specifics, and sent Brevium out to reactivate those as priority.
mhm,
That's kind of the beautiful part about Brevium that I like so much, is that you can prioritize based on multiple things. But like,
mhm,
let's say, for example, it's the fourth quarter, we're cataract surgery heavy, but we never want to let go also of glaucoma. So I
mhm,
like place cataracts that need to be reactivated right above or similar to glaucoma. Like now we're doing reactivations on both at the same time. And then I
Mhm.
could take regular dry eye patients and then move them a little bit down to, you know, uh, lower on the totem pole of reactivation. You don't want to ever not try to reactivate them, right?
mhm, mhm,
But
Right. And the reason I'm just going to
that's
read between the lines, Casey, the reason that that is because a lot of times the dry eye disease management, at least in large part, it can be elective, some of it. And while there are some things you can do to submit to insurance, but the big ticket items, end of plan year, we want to get those folks in because their insurance is ripe for it. Where, if they're paying cash today, they'll also pay cash in January. That's no problem.
right. Yeah.
Okay.
Yeah, the second part of that is Casey, you've been so great at working with us with our AI conversational voice technology, different things like that, and even using our virtual refractive coordinator, which we named Casey because she gave us the idea for creating something
Are you
like
serious right now?
yeah,
Yes.
100%, 100%.
And
So
Matilda wasn't even in the running.
no, it wasn't. It was close. It was a close second. But one of the things that we were thinking is, what about conversational AI texting to reach out and do the initial outreach and whatever that message is, but that AI texting agent has the ability to start to have that conversation to give a little bit of pre-education and then schedule up a phone call with one of your team members or whatever it may be. So there's a lot of different
Yeah.
ways that we can do this that don't require you to have people that have to pick up the phone,
Mhm.
disrupt what they're doing right now, and just some food for thought.
Yeah, that's right, Bill. And one of the things that I think, because, as a marketing communications guy, I run right to what do we say, right?
Mhm,
And the reason why we're starting with Brevium, which is a pretty unsexy place to start for a marketer, but it's like, first of all, like, who are we talking to? Okay. And, past patients put their trust in us. We know they're walking around with a disease state that's progressing. Okay, then how are we going to engage them? That's rolling up our sleeves with the team and making sure we not only have a protocol for how things escalate, but the team knows how to engage. And now we've got, who, we've got how, and now what do we say?
mhm,
And so I think that's the natural progression of things. But you can see, I mean, I don't mean to, Bill, you and I met when there was little LASIK heydays. I mean,
yeah.
this feels a lot like that back in the day.
Mhm,
Like we're probably going to have an IG coordinator. We're probably going to have a special IG consult, like all the things that we used to have to track this progress. So Casey, I'm gonna, we could keep you on forever because you're always the tip of the spear when it comes to implementing new things. Thanks for coming back and sharing with us. I'd like to chop up a lot of this information for sound bites because I just think it's so helpful the way you've broken apart the work into pieces and it makes it digestible for folks. So thanks for continuing to be a good teacher and sharer. And then everybody else, thanks for continuing to come on to the webinar and share insights. Um, this is an ecumenical place. I don't mind companies being on. I don't mind practices being on. I think we all have something to learn from one another, and especially in this category, which is among the more righteous of the ophthalmology categories. I mean, we're fighting loss of vision. How perfect for us. And so that's easy to get behind. I do want to mention that next week we're going to have an update from our friend Chris Moore. It's going to be on December 11th. He's going to talk about where we are with the private equity landscape. It's been a whirlwind the last couple of years, and what thought everybody thought was going to be a little bit of a layup. Turns out you have to work for it. And he's going to have some nice insights to share with us. So when those invites start to come out tomorrow and throughout the end of the week, be sure to plug them if you're willing to, and hopefully we see you then. Kasey, thanks for a great job, as always.
Thanks for having me back, Matt.
Yep. Have a great week, everybody.
I guess.
Bye bye.